Okay, this chapter, which is 14 in the newer versions of the textbook, actually used to be subdivided into two chapters. So acute neurological disorders is what we're going to cover first. And then we'll follow up part 2, chapter 14b, after this one. So this is acute neurological disorders. And we're going to look first at the general effects of neurologic dysfunction. Local effects depend upon the specific area of the central nervous system in which the lesion is located. Now remember that the central nervous system, we're talking about the brain and the spinal cord. Now, the tentorium is an area which is between the cerebrum and the cerebellum. So the tentorium is that division where you have that cerebellar falx. So supratentorial lesions tend to occur above that area, so in the cerebral hemispheres above the tentorium cerebelli. Infratentorial lesions are located in the brainstem or below the tentorium, so it could also be in the cerebellum as well. Left and right hemispheres types of damage. Left hemisphere damage, remember there are some centers of function that are dominant on the left. Remember that logical thinking, analytical skills, science, math, those types of centers are more dominant in the left hemisphere. Speech centers, language interpretation, those centers tend to be dominant in the left hemisphere. Remember we talked about Broca's area, Wernicke's area. Broca's for motor speech, and then Wernicke's is understanding language. Right hemisphere damage impairs the appreciation of music and art and causes behavioral problems. So a lot of your cognitive abilities related to social engagement and interaction with other people are located in those areas too on the right hemisphere, and also appreciation of the arts and music. So it shows you there is this lateralization of functioning, and it becomes very apparent when you see damage to either the right or the left hemispheres. Spatial orientation is dominant on the right. Recognition of relationships may be deficient, so recognizing faces, being able to be more aware of the emotional context of a relationship may be lost, and so that may lead to behavioral problems too. So depending upon where it is too, it could result in interference with mobility, because remember when you talk about the precentral gyrus, in that region of the cerebrum is where you find the motor areas that are connected to various limbs of the body, and various muscle groups. Neglect of the contralateral side of the body happens sometimes where a person that does not have that part of the brain connected to that particular limb doesn't identify that limb as belonging to the person. So they tend to have this neglect syndrome where they feel like that limb doesn't belong to them anymore, and this does happen. So sometimes a tremendous amount of therapy has to be worked into the treatment plan for somebody that has brain injury, some kind of neurological dysfunction. One of the things that happens a lot of times when you do have a brain injury is you start losing consciousness or not being responsive, and that's one of the earliest signs of acute brain disorders. So what you would see manifested would be very kind of lethargic, just not having very much energy to do anything, being confused, being disoriented, having a problem with memory, not responding to verbal stimuli, or just not being able to be aroused in general. The Glasgow Coma scale are standard categories that provide consistency in the medical assessment. The most serious level is a coma, which is the loss of consciousness, and the affected person does not respond to painful or verbal stimuli, and the body is flaccid, although some reflexes may be present. Vegetative state is where you have a loss of awareness and mental capabilities resulting in diffuse brain damage. The brainstem function continues, but the person is actually unresponsive to stimuli. There is a condition called locked-in syndrome, where an individual with brain damage is very much aware of what's going on around them and is capable of thinking, but is unable to communicate, and so they're virtually, paralyzed. Some people can communicate, though, with eye movements if those muscles are still intact. Now, the criteria for what is called brain death, and these are subjective, and sometimes with instrumentation you can determine a loss of function, but cessation of all brain function is represented by a flat electroencephalogram. So EEG is flat. Absence of brainstem reflexes or responses. Absence of spontaneous respirations when the ventilator assistance is withdrawn, so that shows that the brainstem is not functioning. Establishment of the certainty of irreversible brain damage by confirmation of the cause of the dysfunction. So a lot of criteria goes into determining whether a person's situation is permanent or whether it's something they can recover from. General effects of neurologic dysfunction. Motor dysfunction. When you have damage to the upper motor neurons in the cerebral cortex, in the frontal lobe, which is precentral cortex, precentral gyrus, or the corticospinal tract of the brain, affects voluntary movement, causing weakness or paralysis on the opposite side of the body. Now remember, the descending pathway coming from that precentral gyrus affecting motor function is a 2-neuron pathway. So we're talking about the upper neuron. That upper tract, if that or the brain area that it comes from is affected, this is where you will have this condition. Now, the second neuron in the pathway is still intact. So that intact spinal cord connection from that nerve to the muscle continues to conduct impulses with no moderating or inhibiting influences sent from the brain, which causes contractures in the affected limbs. So reflex action, although not controlled, can still occur. If you have damage to the lower motor neurons, that's the second neuron in the pathway, anterior horn of the spinal cord, or the nerve, the axon that goes out to the muscle itself, causes weakness or paralysis on the same side of the body at or below the level of damage. The affected muscles are usually flaccid and reflexes are absent because the connection from the spinal cord or originating of the spinal cord to the muscle is interfered with, so you don't have any reflex action or any contraction at all, so the muscles are generally flat. Okay, sensory deficits. Sensory loss may involve touch, pain, temperature, and position, and the special senses of vision, hearing, taste, or smell. And remember that the sensory cortex comes from areas other than the frontal lobe. Visual loss, hemianopia, can involve the optic nerve, the tracts or occipital nerve, which is where your vision centers are located, and the degree of impairment depends on which part of the visual pathway is affected. So this is looking at a picture showing you where the damage is and what type of blindness that you would have, and this is showing you the eye, the optic nerve, and there's your optic chiasma, and then going back to your optic tracts, and then your radiations back to the occipital lobe of the brain where visual input is interpreted and identified. So if you have damage to the right eye or to the optic nerve, so in this area here, the eye that's going to be affected will be the right eye, and the left eye will be normal. If you have damage to the optic chiasm, then both eyes are affected because that's where your integration center is, and both eyes are blind. If you have damage to the right occipital lobe or right optic tract in this area here, you're going to lose the left visual field because the right side, that hemisphere, controls the left, what's coming in from the left side of the visual pathway. So you see here that that left side is lost in both the left eye and the right eye. Language disorders are generally called aphasia, inability to comprehend or express language. Now remember, we talked about Broca's area being the motor area for speech, and language understanding and interpretation is Wernicke's. So expressive or motor aphasia, impaired ability to write or speak fluently, Broca's area of the frontal lobe, and generally Broca's area is dominant in the left hemisphere. Receptive or sensory aphasia, unable to understand written or spoken language, that is Wernicke's area, which is located in the left temporal lobe. Global aphasia, cannot express self or comprehend others' language. That's a combined effect of damage to both Broca's and Wernicke's. Seizures are spontaneous discharge of neurons in the brain, may be precipitated by inflammation, hypoxia, which is a lack of oxygen to an area of the brain, or it could be a result of bleeding in the brain. The term increased intracranial pressure, ICP, is common in many neurological problems, including brain hemorrhage, trauma, edema, infection, tumors, or accumulation of excessive amounts of cerebral spinal fluid. And if they do a spinal tap or take a spinal fluid to check for any type of abnormalities, they usually, the tap is in the lumbar area of the lower back between vertebrae 3 and 4. So a manometer can be inserted into the syringe, withdrawing cerebral spinal fluid to measure the pressure of the fluid. If you have a pressure of 720 millimeters mercury pressure in that area, that indicates increased intracranial pressure. Pink fluid indicates a hemorrhage. If it's cloudy or if it's yellow, then that means there's an infection. And if you have an abnormal protein level in the fluid, it indicates a neoplasm. Most often, if you're looking at healthy, normal cerebral spinal fluid, it looks like water. Herniation is when a mass, a clot, or a tumor becomes large enough to displace the brain tissue. This is a picture looking at increased intracranial pressure and possible herniations. So here you see a herniation of the area of the cingulate gyrus, which is part of the limbic system, and this is under the falx cerebri, which is the double layer of meninges that goes in between the two hemispheres, right and left cerebral hemisphere. There's your tumor, which is causing pressure that results in these herniations. Here's another area that can herniate. This is called the uncal herniation of the temporal lobe into the tentorial notch. And here's a cerebellar herniation into the area of the brainstem, and that can result in a downward displacement of the brainstem through the tentorial notch. This is showing you an illustration of where they would do the lumbar puncture to obtain cerebral spinal fluid. So you can see it's between L4 and L5. Now we're going to move on to acute neurological problems, starting with brain tumors. Brain tumors are space-occupying lesions that cause localized dysfunction related to their location and the effects of increased intracranial pressure. Gliomas are the largest group of malignant tumors, and they arise from the supporting cells. And the one that's usually the problematic cell are your astrocytes. Remember, your astrocytes support your neurons and keep the capillaries in close proximity to the neurons. They are the most numerous. They do divide and replicate, so they're the ones that cause the problems most often. Also, tumors can occur in the meninges. You can have a meningioma. If it's in the pituitary gland, that's called an adenoma, because the pituitary gland is made of glandular tissue, and adeno means glandular tissue. Treatment, surgery, chemotherapy, and radiation. Now, there could be problems with the blood supply, so you could have a vascular disorder. Global cerebral ischemia occurs when the impaired perfusion of the entire brain results in loss of function and generalized cerebral edema. Now, Transient ischemic attacks, TIAs, these are what we call mini strokes, and this is a temporary localized reduction of blood flow to the brain. It usually will serve as a warning of a passive CVA, which is a cerebral vascular accident, a completed stroke. But not all strokes are preceded by TIAs, so many strokes don't always precede a larger stroke. A lot of times they do, but you can have a full-blown stroke without any warning. Signs and symptoms of mini strokes, TIAs: muscle weakness in an arm and a leg, visual disturbances, numbness, paresthesia. That word means unusual sensations, like, prickly sensation, pins and needles in the face. May last from a couple minutes to 1 to 2 hours. A cerebral vascular accident, a stroke, is an infarction, a complete blockage of the blood supply to brain tissue that results from a lack of blood, and that brain tissue will die. Types of CVAs: a thrombus, an embolus, and a hemorrhage. Risk factors for CVAs. There's a list: diabetes, hypertension, high cholesterol, hyperlipidemia, atherosclerosis, a history of TIAs, increasing age, and heart disease. All are risk factors associated with developing a stroke. Anything that's going to impair the blood flow to a particular area of the brain. Warning signs for stroke: sudden transient weakness, numbness or tingling in the face, an arm or leg, or on one side of the body. Temporary loss of speech, failure to comprehend or confusion, sudden loss of vision, sudden severe headache, unusual dizziness or unsteadiness. Immediate medical treatment may prevent permanent brain damage. The sooner that you get treatment, the better chance for recovery, or the better chance for minimal types of permanent damage. And that's what you're looking to do, is get to that as soon as you possibly can. Clot-busting agents: TPA, tissue plasminogen activator, to activate the process in the blood to break up the clot. So plasmin is your clot buster. This is tissue plasminogen activator, which will activate the plasmin. Or possibly surgery. If you treat the underlying problems, 20% of stroke patients will die within the first few days, but a complete recovery is generally rare. There's always some residual effects, but speed and just getting to this rapidly, that is the best course of action. Cerebral aneurysms, a localized dilation in an artery. Cerebral aneurysms tend to occur at the points of bifurcation. This is where you have 2 or more blood vessels branching off at the same place. And usually this happens at a place called the circle of Willis, which is the circulation that's under the brain. So if you look at this picture, this is showing you the circle of Willis, okay? And those are, this is a bifurcation, is where you have a couple that branch off. This is showing you here a Berry aneurysm, which is off from the circle of Willis. And Berry aneurysms are very common. And when you have one, you probably will have more than one. This is a nice example of a bifurcation right here, where you see 2 vessels that are branching off of the circle of Willis. And that's usually a point of weakness, and some people are more prone to these than others. And here you can see in this picture of the cartoon, there's an aneurysm there, there's one there, there's one there, there's one there. So areas where there's a weakness in the vessel is where you're going to be. And abdominal aortas are also quite common. And those have to be watched. If a person has one, they have to monitor the pressure and make sure that they don't grow in size. Signs and symptoms of cerebral aneurysms: headache, loss of vision, confusion, slurred speech or weakness. If the aneurysm ruptures, death can occur shortly thereafter. Treatment is getting these things before they burst. An aneurysm diagnosed before rupture can be treated surgically as soon as possible by clipping or tying it off. 35% of patients die with initial rupture, and 15% die of a second rupture within a few weeks of the first one. So like I said, multiple aneurysms usually occur within the same person. So finding one is probably more. Infections. Meningitis. Meningitis is a bacterial infection of the meninges of the central nervous system. An infection will spread rapidly through the brain coverings and into the cerebral spinal fluid, and this inflammation leads to increased intracranial pressure. Causes. Different age groups are susceptible to different pathogens. In children and young adults, Neisseria meningitis, which is also called meningococcus. This causes several things. It causes a petechial rash, which you can pick up when this is one of the symptoms. But this particular bacteria is carried in the nasopharynx of asymptomatic carriers. So it's one of the normal flora in the respiratory tract, and it's spread by respiratory infections to areas where it isn't supposed to be. So if it gets into the cerebral spinal fluid, gets in the meninges, there's no protection against it. So this picture, this illustration is showing you cerebral spinal fluid with neutrophils, and you shouldn't really see all these white blood cells in there, and neutrophils are present when you have a bacterial infection. So this usually is a good indicator that there is an infection there in the cerebral spinal fluid. B is showing you a child with a petechial rash. And then C is showing you one of the complications from having a severe bacterial infection that could possibly lead to meningitis, and this is called Friedrichsen syndrome, where you have a infection that goes into the adrenal glands, and the adrenal glands hemorrhage due to the meningococcal infection. So that's another complication. In young children, Haemophilus influenza is the causative agent many times. In elderly and young children, Streptococcus pneumoniae is the major cause of meningitis. So there's multiple types of bacteria that could be representative of normal flora that just get into the wrong place. Signs and symptoms: severe headache, back pain, photophobia, which is sensitivity to light, stiff neck, seizures from increased intracranial pressure, fever and chills with leukocytosis, increased number of white blood cells indicate infection, and fulminant means aggressive or rapid onset cases. Death can occur quickly from vascular collapse, which could lead to shock. Diagnostic tests. You want to look at the cerebral spinal fluid. So you have to do a tap and do a spinal tap and see what's going on. An aggressive antimicrobial therapy. For example, ampicillin is required along with specific treatment measures for increased intracranial pressure and seizures as needed. Brain abscesses. A localized infection frequently occurring in the frontal or temporal lobes. And with a brain abscess, there usually is necrosis or death of brain tissue and an area of edema. Both surgical drainage and antimicrobial therapy are required, and the mortality rate for brain abscesses is approximately 10%. This is showing you a picture of a frontal lobe abscess, and the infection causes central liquefactive liquefaction, I think I like better, necrosis and surrounding edema. So you can see this area here that looks like it's liquefying. Okay, so very, very serious problem. Like I said, if you get it soon enough, your chances of survival are a whole lot better than if it is allowed to persist. Encephalitis is an infection of the parenchymal or connective tissue of the brain and spinal cord, especially in the area of the basal ganglia, and many may include meninges. Usually this is a viral problem. West Nile virus is a form of encephalitis that is spread from the northeast U.S. caused by a flavivirus spread by mosquitoes. Neuroborreliosis is Lyme disease caused by Borrelia burgdorferi, transmitted by ticks. causes joint pain, cardiac arrhythmias, meningitis, and facial nerve paralysis. There is a vaccine available, but we've seen quite a few cases of this over the years, so it's around, and you'll probably run into this at some point. Rabies, caused by a virus that is transmitted by the bite of a rabid animal. Incubation period is 1 to 3 months. It also migrates to the central nervous system. The symptoms are fever, headache, seizures, difficulty swallowing caused by a muscle spasm, foaming at the mouth. Common respiratory failure is what causes death in rabies. Tetanus, caused by Clostridium tetani. Spores invade the open skin, and there's an exotoxin produced by the microbe that enters the nervous system, and it causes tonic muscle spasms, which results in jaw stiffness, difficulty swallowing, stiff neck, headache, skeletal muscle spasms, and eventually respiratory failure. Mortality rate is around 50%. Immunizations are advised, with boosters as needed or following injury. Poliomyelitis, which is also called infantile paralysis. Now rare in North America because of immunization, but still occurs in other parts of the world. The virus attacks motor neurons of the spinal cord and medulla. Damage ranges from person to person. Reye syndrome. Reye syndrome is linked to a viral infection in children treated with aspirin. Now, acetaminophen is used to treat fever in children, and Reye syndrome will cause acute encephalopathy, impaired function of the brain. Symptoms range in severity from lethargy, headache, vomiting, followed by disorientation, hyperreflexia, hyperventilation, seizures, stupor, and coma. No immediate cure is available, and the average mortality rate is 30%, and neurological damage is possible. So something that can be avoided to not treat children with viral infections, treating them with aspirin. So be very careful about this, and when you're dealing with patients, to make sure that they're aware to use acetaminophen. Head injuries. First one is concussion. Is a reversible interference with brain function. We're hearing a lot more of this associated with sports injuries, whether it be football or boxing, and to make sure that protective gear is worn to prevent concussions. It results from a mild blow to the head, causes movement of the brain, disrupting neurological function, and can also result in a loss of consciousness. Amnesia and headaches may follow, but usually the recovery period is about 24 hours with no permanent damage. A contusion is where you have a bruise of brain tissue with a rupture of small blood vessels and edema that usually results from a blunt blow to the head. Closed head injury occurs when the skull is not fractured in the injury, but the brain tissue is injured and the blood vessels may be ruptured by the force of the blow. Extensive damage may occur when the head is rotated with considerable force. Open head injury involves fractures or penetration of the brain by external objects. Linear fractures, simple cracks in the bone. Comminuted fractures consist of several fracture lines but may not be complicated, and a compound fracture is where brain tissue is exposed. Depressed skull fractures, crushing type of injury, causes pressure on the brain. Basilar fractures occur at the base of the skull, leaking cerebral spinal fluid through the ears or nose, and this results from possible automobile accident type of an injury. Cranial nerve damage and dark discoloration around the eyes is common. Contracoup occurs when an area of the brain contralateral to the side of direct damage is injured as the brain bounces off the skull. Usually the damage on the opposite side is minor compared to the damage from the initial impact side. Hematomas and hemorrhages may develop, and they are classified by their location in relation to the meninges. So here's an illustration showing you contracoup. There's your direct impact area, And then when the head is snapped back, then the contracoup is on the opposite side in the back, where the brain recoils and smacks up against the back of the skull. This is a depressed fracture where the bones are crushed in, and then that can cause injury to the brain underlying that area of bone. And here's where the bone fragments can penetrate and result in very serious injury to the brain itself. So this is closed, the top one is closed, the bottom one is open. Possible effects of head injury. So where you have your trauma, primary damage is direct, a skull fracture, tissue is compressed by the bone, tissue lacerated by bone fragment, results in tissue damage and bleeding, which can cause increased intracranial pressure. A bruise, a contusion, will result in edema and minor bleeding. Brain motion, if the brain actually is rotated, and tissue is torn by the shearing caused by the rotation. Also, contracoup, which we talked about earlier, can lead to tissue damage and bleeding, which can again lead to ICP. Secondary damage, this is primary damage. Secondary damage is the bleeding associated with the injury, inflammation, edema, hematoma, which is a bruise, possible infection, another complication. Again, ICP. Compresses blood vessels, leading to ischemia, impaired blood flow, and necrosis of tissue. And that ICP compresses the brainstem, can end up losing vital functions and loss of respiratory and cardiovascular controls that are in the brainstem. Types of hematomas. Epidural, which is also called extradural hematoma, is where you have a bleed that occurs between the dura, which is the outer layer of the meninges, and the skull. Subdural develops between the dura and the arachnoid layer, because remember when we're talking in A&P about the three layers of the meninges, you had the dura mater, you had the arachnoid layer, and the pia mater. Subdural is underneath that outer tough layer, so in between the dura and the arachnoid mater. Subarachnoid is between the arachnoid and pia mater. And also remember, this is where your cerebral spinal fluid is circulating, so it's associated with traumatic bleeding at the base of the brain. Blood mixes with the circulating cerebral spinal fluid, and so there's no local hematoma, but you do have a lot of spilling off into the cerebral spinal fluid that can be picked up in the spinal. This is looking at a very large subdural hematoma attached to the dura. So you can see on the left-hand side of this picture, you can see, here it is, large mass where blood has escaped, and it's underneath the dura. And look at the pressure. Look at the change it's made in the shape of the cerebral hemisphere here. It's really occupied a lot of space and compressed that area. Intracerebral hematoma results from contusions or shearing injuries that may result in increased intracranial pressure. These can also cause seizures, cranial nerve impairment, otorrhea, rhinorrhea, so leaking cerebral spinal fluid from the ear, from the nose. Otorrhagia is blood leaking from the ear through a fracture site with torn vessels and meninges. Fever, a sign of hypothalamic impairment because your temperature control center is in the hypothalamus, or cranial or systemic infection. Stress ulcers can result from increased gastric secretions. Now this is called Curling's ulcers. Treatment is taking a CT, so computed tomographic analysis or scan, useful in determining the extent of the brain injury. Glucocorticoid agents, anti-inflammatories to reduce the edema. Antibiotics to reduce the risk of infection. And surgery may be required to reduce intracranial pressure, increase intracranial pressure. Headaches may persist for days after the injury. So these are types of hematomas. So there is your extradural or epidural hematoma, and blood's going to fill the space between the dura and the bone. Subdural hematoma, blood fills the space between the dura and the arachnoid mater. And then intracerebral hematoma here is where you have within the brain itself. Spinal cord injuries usually result from fracture or dislocation of a vertebrae which compresses, stretches, or tears the spinal cord. The ligaments that support and the intervertebral disc may be damaged also. Most injuries occur in areas of the spine that are more mobile, so like in the cervical region or in the area of the lumbar region tend to be the most mobile areas, and so that's where you're going to have problems with injuries. But as far as spinal cord, the cervical region, that's where you're going to have the most problem. So C1 through C7 and T12 to L2. Common injuries: hyperextension or hyperflexion of the neck. These lead to cervical spine injuries. Dislocation of any vertebrae may crush or compress the spinal cord and compromise blood supply. Compression fractures, when great force is applied to the top of the skull or to the feet and is transmitted up and down the spine. Penetrating injuries, like either a stabbing wound or bullet wound that penetrates into the space where the cerebral or where the spinal cord is. Treatment: surgery may be required to relieve pressure and repair tissues, glucocorticoids to treat inflammation, and rehab to learn to use remaining functions. These are types of spinal cord injuries. So this is hyperflexion. So you have a torn posterior longitudinal ligament and distortion of the cord here. Hyperextension, like in the case of this poor dude falling down the stairs. Compression of the cord by the ligamentum flavum and disc. Torn anterior longitudinal ligament. And there's your injury. And then a severe fall, falling on your butt really hard, puts a lot of compression on the cord, and this compression fracture can lead to damage of the cord.